As you all know, this is a time when we come together to celebrate either the promotion of someone to full professor or their appointment to that level from outside the school. And so we're here today to celebrate Orin Levine's promotion. And probably everybody in this room knows Orin very well and knows his accomplishments, but I'll just tell you a little bit about him in case there's some tidbits that have leaked, that you haven't heard. Orin is from Baltimore. He went to college at Gettysburg College in Gettysburg, Pennsylvania, and got his PhD in epidemiology here at the Bloomberg School. He was an EIS officer at the CDC and was involved at the CDC for many years. He's most recently, as you know, headed up a number of activities here at the school. His interest has been in the control and prevention of infectious diseases, especially respiratory diseases, especially pneumococcal disease. And for 15 years, he's worked on efforts to accelerate the development of vaccines and introduction of new vaccines against strep, Haemophilus type B, meningococcus, dengue, a whole variety of things. And I'm not going to say anything about that because I assume that's what you're going to talk about. But I learn the most about our faculty when I read the letters that come in from colleagues around the world, or maybe not colleagues, maybe people who are competitors. And so that's how I really learned the impact of Orin's work and the impact that he's had in terms of speeding up the acquisition and dissemination of vaccines has just saved innumerable lives and will continue to do so. And I hope you're going to talk about that work here today. So he leads IVAC, the International Vaccine Access Center, has about 30 professionals with experience in economics, policy analysis, financing, and advocacy that takes the success that he's had and targets it to accelerate global access to a variety of vaccines. He's also, those of you know Orin, know he loves acronyms. He's really good at acronyms. So one of the acronyms that he has is PI of the Gates Foundation funded Pneumonia Etiology Research for Child Health, the PERCH Project. And I often wondered when I first heard that whether that had anything to do with Pneumo, because you give that Pneumo lecture, and whether it was really, you had this thing with fish. But that has 7 sites in Africa and Asia and has a projected sample size of over 12,000 patients and controls. And so it's really going to tell us what causes this syndrome of pneumonia. So I could go on and on. He's written over 100 peer-reviewed publications, but Orin is one of those rare individuals who can do the science and do the research, but then translate that into material and information that all of us and the general public can understand. So he blogs on vaccine and global health for the Huffington Post, and he's regularly on radio, TV, and print on a variety of issues related to vaccines. So I'll stop talking and say, Orin, congratulations. As I said to you individually, I'm cynical about lots of things, but to be promoted at Hopkins to the level of professor is a great accomplishment. It's hard to get on the faculty here, and not many people can do it, but then to have the level of work where somebody achieves the rank of professor, it's a big deal. So congratulations.
Thank you, Mike, for that introduction. That's very kind of you. I'm going to take this opportunity to just talk about one of my favorite things, which is accelerating vaccine access. And when they asked me to give this talk, I thought this is a chance to kind of reflect a little bit and look back. And so I quickly dashed out a title, and I said, are we any better at it now than 10 years ago? And then I realized, oh my gosh, I keep thinking I've only been working on this for 10 years, but it's actually been much longer than that. So it probably should be titled last 15 years, but we'll emphasize the last 10. Here's what I'm going to try and do today. I'm going to try and talk about why accelerating new vaccine adoption, particularly in developing countries, is important and why it comes with high expectations. And then I want to go through a little bit of what we learn, what we think we know, and why we think we know it. And I'm going to emphasize both what has and what hasn't worked. I'm going to use a lot of examples from the experience with Hib conjugate vaccines. And then I'm going to wrap up a little bit with a few thoughts about improving efforts by learning from the past. So vaccine access comes with great expectations, and I think it's really important for us to reflect on why is that? Why do we have a priori, or why did we have, when we started trying to do this, the expectation that we could be enormously successful with global vaccine access. And I think it starts with smallpox. Here's Edward Jenner in 1796, with his famous experiment on James Phipps with vaccination. And we went from there to starting to use vaccines, but then really smallpox eradication, led by our former dean, D.A. Henderson, when he was at the World Health Organization, and carried out by innumerable people. I think Al Summer was a smallpox warrior, and my dad was, other people. But basically what they showed was we could focus with these vaccines for 10 years and wipe out a disease. So beginning in 1967, we had smallpox in just over 30 countries. By 1977, we have no cases at all. And by 1979, the World Health Organization has looked everywhere in the world, and they concluded not a single case left. So this set our expectations high with vaccines. But if smallpox created ambitions of what was possible with the vaccine, the decade of universal childhood immunization, which followed it, cemented those ambitions. It was during the 1980s, after the success with smallpox, that we started to establish immunization systems in every country. So these immunization logistics systems were established in the 80s to be simple, precise, and standardized, to just very simply, but in a routine fashion, make sure that we could do with other vaccines, a package of vaccines, what we had done with smallpox. And so this graph shows global coverage of DTP3 immunization. And DTP3 means children who get 3 shots of DTP in their first year of life. And it's an indication, if you can get 3 shots in the first year of life, of the strength of your system. And in fact, what you'll see is that universal childhood immunization period, that period hallmarked by Jim Grant and his big vision and his mobilization of UNICEF and countries, look at how steeply that black line goes up. In 10 years, we go from 20% coverage with this package of vaccine to 80% coverage in a decade. So in 1 decade, we've eradicated smallpox. In the next decade, we built this delivery system that's given vaccines to 3 doses to 80% of the world. And then in the late 80s and early 90s, we start getting the new vaccines coming along. And this is the story with Hib conjugate vaccine in the United States. After trials by Matu Santoshm and others showed that this vaccine was safe and effective, we started using it routinely in the US. And the rate of decline that we saw, even within the first year or 2 of the use of this vaccine, exceeded our expectations. And if I drew the line out afterwards, you'd see almost no cases of Hib. So our success continued into the 1990s with rapid effects seen from Hib conjugate vaccines. All of these, by the mid-1990s, created an expectation. Smallpox eradicated, global disease delivery system built, global coverage at about 80%, and we had a new vaccine that could be given with existing ones on the same schedule. We'd done all the research and shown that you could give it safely and effectively. So our expectations in the mid-1990s were access to new vaccines should rapidly reach high levels. So in 1995, 5 years after Hib conjugate vaccines had been licensed in the US and elsewhere, how were we doing with global vaccine access? The answer, not so good at all. So this graphic, and I'm going to show you several of these over the course of the presentation, illustrates the uptake. So there should be 4 lines on this graph. 1 line for the Gavi countries, which are the low-income countries of the world. Another line for LMICs that are non-Gavi. Those are low and middle-income countries that aren't eligible for Gavi. Then upper middle-income countries that aren't eligible for Gavi. And then HICs are high-income countries. These are World Bank classifications by income level. So in 1995, you've got about 40% of the world's high-income countries using Hib vaccine, a smattering of the upper middle-income countries, but none of the world's poorest countries are using this vaccine. And that's a big problem, because in 1995, the kids that needed it the most are the ones that are not getting the vaccine. And I'm going to illustrate that point with this graphic, which is a little bit complicated, so let me walk you through it, because there's 4 things going on in this graphic. The y-axis is the risk of dying from Hib disease per 100,000. So the higher you are up on there, the higher your risk of Hib mortality. The x-axis is the log of gross national income per capita. So essentially, rich countries are out on the right-hand side, poor countries are down on the left. The bubbles are individual countries. These are like Hans Rosling's bubbles. Everybody's seen Hans Rosling's bubbles, right? But they don't move. The bigger the bubble, the more total deaths due to Hib you have. And the bubbles that are open, that are unfilled in, mean you're not using the vaccine. And the bubbles that are filled in mean that you're using the vaccine. So basically, you can see that essentially there is a correlation between having a high risk of death due to Hib and being poor. And all of those poor, high-risk countries are open circles. Nobody's using the vaccine. If I could magnify this a whole lot, you'd see a handful of countries down here in the bottom right-hand corner. They're so itty-bitty small in their bubbles, but they're filled in. Those are the rich countries where the risk of disease is very low, and they're the only ones using the vaccine. So this realization that we weren't getting the kind of rollout of vaccine access that we had hoped for spurred a lot of conversation. What drives adoption of these new vaccines? What do we think is behind it? And as this happened with initial efforts were largely speculation and expert opinion. People with a lot of experience telling anecdotes. Well, the prices are too high, or the system's not strong enough. Just show them the burden of disease, or give it away for free, and that'll solve it. But fortunately, it also spawned a series of more systematic investigations, including some descriptive and analytic epidemiology that I want to walk you through, because this became formative in describing what activities we emphasized. We learned a little bit from anecdotes and outliers, from country case studies, from surveys, and from regression analyses. And I'm just going to walk you through a couple of those. So outliers, obviously, a lot of us know that you can learn something from outliers, but it's probably somewhat limited. What we did learn from outliers based on this time is that there were high-income countries that were not using the vaccine. For example, Japan. There's no question that Japan had both the money and the health system to deliver the Hib vaccine if they had chosen to, but they had chosen not to include it. So very simple conclusion, it's got to be more complicated than just money. The decision is not just about money. So then we went and probed systematically and proactively with 4 early adopting countries. Not the outliers that weren't using, but the early adopters who did use before anybody else. What were the factors that influenced your decision? And so together with some colleagues, we visited Qatar, Bahrain, Uruguay, and Chile. And the key findings from these country studies were that disease burden and surveillance data were often highlighted as having been influential in their process, in their decision to introduce the vaccine. That the Ministry of Health and the pediatric community were key in the decision process. That price, even for these relatively more affluent middle-income countries, was still a concern. And interestingly, and maybe much to the chagrin of the health economists in the crowd, cost effectiveness was rarely cited as key to their decision-making. There was also some analytic epidemiology. There was some experience with adoption of new vaccines, most notably hepatitis B vaccine, that was leveraged in this paper by Mark Miller and Dana Flanders. What they did is they took the characteristics of countries who either adopted or didn't adopt hepatitis B vaccine, ran a logistic regression analysis, and then built a sort of predictive or probability of adoption out of those models. And then they overlaid where they predicted adoption would occur with where actual adoption of hepatitis B and Hib vaccines occurred. And here's what they found. The countries here that are in different shades of gray have, based on their model, different probabilities of uptaking Hib vaccine. The black dots represent, as of October 1998, who actually took up the vaccine. So you can see most of the countries that they predicted, the gray countries, have a black dot in them. There's a few that don't. And most of the countries that have a black dot are gray. There's a few that are white. So it seemed like there must be something to this analysis, and maybe it's a useful predictor of some of this. The three key independent factors that came out of that model were disease burden, which they assessed as either life years lost or saved, financing and economics. They put either the cost of the vaccine or the cost relative to your GDP as an indicator, and the strength of your vaccination program. Essentially, higher coverage with DTP was associated with being more likely to use the vaccine. So in the mid-1990s, in response to this environment where our expectations were being met, and in response to what we were learning from this epidemiology of vaccine adoption, such as it was, we pursued some interventions to accelerate uptake. So now we can move from kind of, observational interview type studies more into observational, almost experimental. And I want to review what was our experience with the disease burden support intervention, and what was our experience with what I would call epidemiology or epidemiologists' approaches to the financing and economics obstacles. So in order to understand the interventions on the Hib disease burden side, you have to understand a little bit about Hib disease burden. There are three major syndromes of Hib: meningitis, pneumonia, and then these other invasive syndromes like sepsis, bloodstream infections, or potentially life-threatening but fairly uncommon infection called epiglottitis. But meningitis and pneumonia are the two major ones. And the other thing you need to remember is that in the US and Europe, meningitis was the main driver of Hib vaccine uptake. Before we had Hib conjugate vaccines routinely in this country, Hib caused about 1/2 of all the pediatric bacterial meningitis cases. And just to give you an idea, that was about 10,000 cases of bacterial meningitis every year in this country. The costs of caring long-term for patients who had sequelae, who survived Hib meningitis and needed long-term care, that was so high in this country that it alone was sufficient economic rationale to introduce the vaccine in this country. So in the US and Europe, it was meningitis and costs of caring for meningitis sequelae that were really the main drivers for vaccination. So in 1996, the World Health Organization is getting requests from its member states saying, we heard about this Hib vaccine, we're starting to think about it, but we don't know what our burden of disease is locally. Can you help us figure out what that burden of disease is? And so the response was, actually they asked CDC to help them write a generic protocol. They asked actually my boss at the time, Ann Shookett, who some of you may have seen on Vaccine Day, and she came to me as an EIS officer and said, do you want to do this? And I said, sure, that'd be great. And so we put together this manual for measuring the incidence of Hib meningitis in countries. It was translated into all these countries. This was the bulk of the WHO response to country requests for disease burden help, emphasizing meningitis incidence. We had one page in this document dedicated to pneumonia calculations. It was the back page, and we literally put it in at the 11th hour as we were about to ship the thing out, and thought, gosh, maybe we should put something in there about pneumonia. It's going to be an important point, as I'll point out in a few minutes. So now, looking back, we can evaluate, was that emphasis on Hib meningitis incidence executed well, implemented strategically, and was it the right emphasis for developing countries? And we're fortunate to be able to do this based on work that we did as here at Hopkins in conjunction with the World Health Organization, CDC, and the London School, as part of an effort to develop country-specific estimates of the burden of Hib and pneumococcal disease in children under age 5. In that project, we had this goal that every country should have a country estimate based on as much local data as possible and modeled from neighboring data wherever needed. So we went out to estimate cases and deaths for meningitis, pneumonia, and the other serious infections. We conducted a systematic literature review, All the data sources, methods, and assumptions were transparently documented. And very importantly, we included a data quality assessment for the meningitis study. So it wasn't enough to be published. You also had to have the quality of your study judged. And we concluded with recommendations for improving precision, robustness, and usefulness of these estimates. The goal was, at the end, every country would have these estimates. And here's what we found. First of all, there were 110 papers of meningitis that were published. Of those, 78 came from countries where the epidemiology of child mortality was characterized as very low, countries like the United States. Only 14 came from countries with high mortality risks. And importantly, and a little bit shockingly, I must say, as somebody who was working on Hib and other bacterial meningitis epidemiology at the time, when we independently assessed the quality of what we published, 50% of the studies did not meet an A or B quality rating. This was a big wake-up call for us. And data quality turns out to matter, and it particularly matters for those high mortality countries. So here you have the incidence of Hib meningitis reported in the studies on your y-axis. And then you have the data stratified now by the mortality level of the countries and by the quality of the study. Essentially, if you look down here in the bottom left, in the very low mortality countries, you get basically the same rate, whether it's an A, B, or a C quality study. In the medium mortality countries, maybe there's a little bit of a difference if you stare at this for a long time, but in the high mortality areas, there are very few studies, but it does appear that you actually get perhaps a substantially lower incidence level when you don't do the study as well. And so that really pointed out some of the shortcomings. In addition, we saw regional problems, and Asia has always been one of the really vexing areas for us on the adoption of these new vaccines, especially the bacterial vaccines. So just to give you an idea how representative our data were from Asia at the time, if you look at the population of Asia, about a third live in urban areas, about 2/3 live in rural areas. There were 16 studies that were published from Asia from urban areas. So if you had been strategic about this and proportional, you'd have expected 32 studies from rural areas. We had exactly 1. Now that's a pretty small p-value, but it also points out that we had an underrepresentation of rural Asia. Then lastly, a word on the syndromes. We usually talk about Hib disease as an iceberg, or when I go to Africa, I talk about the eyes of the hippo because they don't have a lot of icebergs in Africa. But the culture-positive Hib disease that we can measure easily through our routine surveillance is only a fraction of the burden of disease. Most of the burden of disease is culture-negative patients who don't have a positive culture from blood or CSF, but have, say, a pneumonia. And we know this from studies like this one in Chile, a randomized controlled trial of Hib vaccine, where one half of the city of Santiago, the kids got DTP alone. The other half got Hib and DTP. And what you see is what we measured in that Hib meningitis protocol. That's the top row here. By measuring the disease with culture-confirmed endpoints, we could see that we prevent about 40 cases of culture-confirmed Hib disease for every 100,000 children under age 2. When we look, though, at the X-ray pneumonias and the difference there, we ignore the culture results. We get about 6 times as many cases prevented. And it really speaks to the burden of the culture-negative pneumonia relative to the Hib meningitis and other culture-positive disease. This is reflected in the global disease burden estimates. You can see that only about a quarter of the total deaths due to Hib disease are due to meningitis, and about 3/4 are due to pneumonia. So working on more precision on the meningitis side, that's just not going to make your big bang. So go back to those questions I started with. Was the emphasis on Hib meningitis incidence executed well? 50% of our published studies were C quality, so I would offer that we could probably have done better on the quality of our studies. And that the C quality studies were associated with lower observed incidence rates in high mortality areas. So we may actually have preferentially or selectively actually really underrepresented the disease burden in some of those places. Was it implemented strategically? I think we could have done a lot better there. The very low mortality in urban areas, especially in Asia, were overrepresented, and the high mortality in rural areas were underrepresented. And was it the right emphasis for developing countries? We know that meningitis was a big deal here and a key driver, but what about for them? Well, most deaths are Hib pneumonia, not meningitis. So variations in that meningitis rate are only going to make a small change in the overall burden, whereas a change in understanding the proportion of pneumonia might make a big difference in your total burden. So I think there's some lessons from this global disease burden process for improving the epidemiology of early on to help the new vaccine introduction process. First of all, I really learned the value of systematic literature reviews, and I would start with those. And then put those into models. And secondly, use those models to assess how quality, representativeness, and types of data will change those estimates. Those will tell you where you get the most bang for your buck from investments in getting new data. So build those epi studies to fill the gaps that will influence the overall estimates. And lastly, where you can show that actually additional data are not really going to change your country's estimates, try to emphasize in the dialogue with policymakers the use of data from neighboring countries and high-quality studies elsewhere, so that we don't spend a lot of time on sort of studies that predictably are not really going to change their decision. So that's a quick wrap-up of some of the disease burden interventions of the period. How about the financing and pricing obstacles? Well, a lot of the effort in this period was in the hands of epidemiologists, and being one, I'd like to think we're very creative and have a lot of solutions. And we put our heads together trying to figure out what are some financing problems that could be overcome with epidemiology. And one of them in Hib vaccine was, well, what if we just use fewer doses, right? We know something about the effectiveness of this vaccine now. We've been using it in the US and elsewhere for more than 5 years. It's normally a 3-dose regimen. What if we just go to 2 doses and we don't have to pay for that 3rd dose? We also knew that particularly one of the vaccines, the PRPT vaccine, which has 10 micrograms of PRP, the capsule, in its licensed formulation, probably had more of the antigen than it needed. So we said, well, what if we took one of those single-dose vials that they sell for $3 a dose, and what if we just drew 2 doses out of that, 3 doses? What if we just fractionate it? One study even split it into 10. And here's what the study showed. Here's a study from Chile where they used 2 different Hib vaccines, a PRPT vaccine and then another using a different carrier protein called CRIM197. The vaccine's called HBOC. Each of the vaccines, kids got randomized into one of 4 groups. You either had the standard regimen of 3 full doses, or you had 3 1/2 doses, or 3 1/3 doses. And you can see the volume was actually smaller. We just took a single vial and we just drew out a little bit less and a little bit less, or the 2-dose regimen. And here's what we found. We found basically less is more with PRPT. So if you look at the anti-PRP, that's the protective antibody in Hib disease, at age 8 months, this is 2 months following their culmination of their regimen, this is what you saw in terms of geometric mean concentrations. PRPT, the 10 microgram column here on the left, that's 3 doses of the full dose. The 5 micrograms, that's 3 doses of the half. The 3.3, that's 3 doses of the 1/3 of a dose. And the 2D column, that's the 2 dose. Basically, the immunogenicity got better with fewer doses or with lesser volumes and lesser amounts of the antigen. With CRIM 197, the other one, we did not see that. In addition, studies giving a plain PRP booster and looking at the anamnestic response, both in Santiago and studies we did in Dominican Republic, showed that the lower concentration vaccine gave better booster responses with higher affinity and avidity. And what I think was the coolest study, and the one that I wish we'd done, was the one they did in South Africa, where they took a single-dose vial of Hib and a 10-dose vial of DTP, and they just reconstituted that Hib single dose with 10 doses of DTP. They had a DTP Hib combo in a 1/10 dose preparation. And here's what they found. No difference in the seroconversion rates. This first row, post-primary percent antibody concentration above 1 microgram, that's basically, are you protected against Hib disease? No difference, 94 and 95%. The GMCs, both whoppingly high, and importantly, post-booster, again, same phenomenon. The lesser concentration gave better booster responses. So in summary, we proved through a series of studies, fewer doses were likely to be protective, could reduce cost by 33 to 67%, but less if the vaccination status was unknown because you would not withhold the vaccine. And it's probably feasible in some settings to just say, give just 2 doses than 3. Fractional doses were also likely to be protective, could reduce cost by at least 50%, maybe up to 90% if you look at that PRPT data from South Africa, and feasible in some countries. And the US Pharmacopoeia, a group that reviews drug information and makes recommendations about it, looked at all this data. And if you look at the bottom paragraph here, it says, based on the recommendation, fractional doses of Hib conjugate vaccines were added as an acceptable off-label use for use in resource-poor countries. So you had a pseudo-recommending body saying it's okay to do that. So what happened? Did fractional doses accelerate Hib introduction? No. 0 countries have adopted a reduced antigen or fewer dose schedule. But the good news is that financing solutions have emerged, but primarily from financing institutions and experts. So I take this as, one sort of serving of humble pie, that as much as I wanted to be an epidemiologist coming up with financing solutions, sometimes the best solution to financing problem is financing specialists. One of the other barriers that we talked about a lot when we were introducing Hib vaccine was this notion about the systems. And I heard this language explicitly in the halls of WHO. The EPI system is actually a house of cards, they said. If you put one more card on top, the whole thing's going to fall down. And again, now that we're some years out, we have the ability to look back and say, well, what happened with that? Was that really a concern? And I'm going to present today some data from an unpublished manuscript that I'm working on with Jessica Shearer, a former student here, Damian Walker, former faculty, and Nicholas Risco, also another former student here, on the impact of new vaccine introduction on the coverage of existing vaccines. And our hypothesis is simple. If the EPI system is a house of cards, then introduction of a new vaccine in year 0 should be associated with a decline in coverage with existing vaccines 1 or more years later. So we used all the data available from the World Health Organization on DTP3 coverage by year and by country. And each one of these lines is a country, and their data from 2000 and 2009. And as you can see, there's a lot of variability in coverage, both from year to year and across countries. So one of the things we got to think about is just because DTP3 varies doesn't necessarily mean it's a new vaccine introduction. So we tried to figure out how do we do that. So we built these longitudinal mixed effects regression models looking at the effect of new vaccine introduction on subsequent DTP3 coverage. We looked at the years 99 to 2009. We had 176 countries with data and 185 events, if you will, of new vaccine introductions, places where there their schedule, their vaccine program changed by introducing a new vaccine. And we threw into the model covariates that we thought would also potentially reflect drivers, independent drivers perhaps, of DTP3 coverage, things like gross national income per capita, Gavi eligibility, whether they're a country in conflict, what their coverage is with antenatal care, which is another indicator of primary health care services, their infant mortality rate, their private health expenditures, and their overall health expenditures per capita. I'll go through the key findings pretty quickly. First, DTP3 changes can be large and occur frequently. You could probably have seen that from the first graphic. There were 1,558 interannual changes that ranged from 1% to 56% from year to year. About 17% of those were outside of the expected range of fluctuation. Two, the coverage trends differed by income groups. So in the year 2000, median DTP3 coverage in low-income countries was the lowest of any of those income groups and the most variable. And since 2000, the median DTP3 coverage has increased more in low and low-middle income countries than it has in high-income countries. And that's sort of described here. In this graphic, each of the y-axes is the DTP3 coverage rate. Each of the quadrants here represents a low-income, low-middle income country, upper-middle income country, or high-income country data. And what you can see is the high-income countries down here in the bottom right, basically they've been high and with very limited variability the whole time. Upper-middle income countries, high, relatively limited variability, some sort of egregious outliers in there. Low middle income countries, a little bit lower, a little bit more variability. And the low income countries were really characterized at the beginning of the decade by much lower rates and much more variability. And towards the end of the decade, higher rates and less variability. Most importantly for us, for what we were looking at, DTP3 coverage is not associated with the introduction of a new vaccine. So there was no association between new vaccine introduction and subsequent DTP3 coverage, either in the house of cards way or in the largely in the positive way. There was one exception, which was for those countries where their very first new vaccine introduction, they seem to have had a positive change in DTP3. Interesting finding to be explored a little bit longer. It's sort of counterintuitive that the more you do it, the worse you get at it. But that was one of the findings. And then there were other factors that do drive DTP3 coverage. Coverage was positively associated with calendar year increasing over time, coverage of antenatal care, health expenditures per capita, and as a sort of indicator of infrastructure, the coverage of paved roads, but that was exclusively in the Gavi eligible countries. In the other direction, DTP3 coverage was negatively associated with existence of conflict, having a high infant mortality rate, and a higher percentage of health expenditures that are private. So on the system side, we can look back and say the new vaccine introductions did not bring down the house of cards, and in some cases may have positively increased coverage. Most introductions in this period, though, were essentially substitutions with combo vaccines. So we were using DTP vaccine, and now we're going to swap that out for a vaccine that has DTP Hep B Hib. We're going to start increasing the number of injections that kids get and the complexity in the years ahead. So continuing monitoring may be required, and actual mileage may vary going ahead. Substantial variations in DTP3 coverage are definitely observed. They seem to be largely driven by other factors, and this points out that we still need to do quite a lot to strengthen our immunization systems. So now I want to start thinking about the last 10 or so years from 2000 to today, because I've set you up with essentially where we started in the mid-90s with this expectations not being met and why, and how do we kind of get our heads around it, and essentially a period of mixed impact. So what about from 2000 and today? Because the new millennium was a really big deal. It was a big deal in vaccines mostly because of this. Bill Gates stood up and announced creation of the Gavi Alliance. He and his wife's foundation pledged $750 million over 5 years to Gavi. And Gavi, in turn, said, we're going to take this and buy vaccine, and we're going to offer free Hib vaccine and other types of support to the 72 poorest countries in the world. The reaction in the immunization community was fairly predictable. Ka-ching. We thought, look, conventional wisdom says our financing problem is solved, so access should take off, right? This was the big answer to a lot of the financing stuff. So did it? Well, look, here's what happened. We did see an acceleration. We did see some improvement. In this graphic, I've got the proportion of countries that have introduced Hib vaccine on the y-axis, and I got time on the x-axis. Got two curves here. The high-income countries are yellow, and the blue line are the Gavi-eligible countries, essentially the 72 poorest countries of the world, the low-income countries. And what you see is from 2000 to 2005, there was an increase, but a fairly modest increase, given that we just offered free vaccine to all of them. So what are the insights from this period? The situation was we had a Hib combo vaccine. It was eligible for procurement through UNICEF. Gavi's buying it, offering it free for 5 years. But there were concerns by countries. What happens after the 5 years? You know, what's the price going to be? Those kinds of things. And one other point. At this point in time, WHO has made a recommendation for Hib vaccine, but it would be a tepid recommendation at best, as I will show you in a minute. And the result was modest acceleration. And this was acceleration. If you compare this to hepatitis B at the same point, there was some improvement, but very modest. The conclusions, I think, from this period are, again, financing alone is not sufficient. And I think one of the really key findings, as you'll see in a minute, is that the policies that were in place did not reflect confidence in the disease burden. And this turned out to be really important. This is what the recommendation from the World Health Organization looked like in 1998 to 2005. In view of the demonstrated safety and efficacy of Hib conjugate vaccines, good start, Hib vaccines should be included as appropriate to national capacities and priorities in routine infant immunizations programs. In geographical regions where the burden of Hib disease is unclear, efforts should be made to evaluate the magnitude of this problem. This is hardly a ringing endorsement for getting on with the vaccine. So what happened after 2005? Well, after 2005, we got big acceleration. And this slide points out some of what I think are the really key milestones here. So 2005, the big key milestone is this Hib initiative was created by Gavi, recognizing that financing was not alone going to solve their problems. They created this dedicated team, and it was based here at Hopkins and worked out a consortium that included CDC, the London School of Hygiene and Tropical Medicine, and in close collaboration with the World Health Organization. In addition, Gavi got more money. Its first 5 years were up. It got a new pledge, and this time Gates pledged 10 years of funding. In addition, by 2007, the WHO has now issued a strong recommendation, and that global disease burden project that I talked to you about, it's now generated country-specific estimates. So every country in the world has a number to say, how many cases and deaths do I think I have of this disease? So for me, the insights from 2005 to now are really much more illuminating. This is our interventional period. Vaccine supply improved. Gavi's got up to 10 years of funding. There's only a low copayment associated. You have to pay between 15 and 30 cents a dose to get Hib vaccine. Gavi pays the rest. So the longer funding, the new suppliers diminish concern over the price after Gavi support ends. The WHO offered a strong recommendation, and the Hib initiative drove evidence-based advocacy and policy changes using the new data we had on estimates of the burden of disease, the new data that we had behind the recommendation, et cetera, and the result was rapid acceleration. And I would offer to you that I think what this says to us is that the equation that we need in place to accelerate new vaccines is financing plus supportive policies plus adequate supply plus advocacy. And just to give you an idea how different the recommendation was, this is what the current recommendation looks like. In view of their demonstrated safety and efficacy, Hib conjugate vaccines should be included in all routine infant immunization programs. No hedging there. And in a really very major reversal, Lack of local surveillance data should not delay the introduction of the vaccines, especially in countries where regional evidence indicates a high burden of disease. So there's data from your surrounding countries, don't ignore it. As we end here, I want to just shift from Hib into pneumococcal. Pneumococcal experience was so aided by being able to learn from the Hib experience. And by learn, I mean both what did and didn't work. And the most important thing we got from Pneumo was, from Hib for Pneumo was, you got to start earlier. And so I just list a series of sort of milestones from licensure to, procurement that are key drivers of the accelerated process. And I show you when it happened for Hib and when it happened for Pneumo. And the rightmost column is essentially what's the delta there? How many years accelerated were we on doing these critical steps? And pretty much every one of those we were accelerated, with the exception of procurement. And in some cases, substantially so. And I think there's evidence that, that's working. The evidence is here. So here we compare the uptake of Hib and Pneumo vaccines in high and low income countries. So on the left-hand side of the curve, these diamonds, the blue one is pneumococcal conjugate vaccine, the red one is Hib conjugate vaccines. Essentially, these curves are about the same. So in high-income countries, these two vaccines were rolling out about the same pace. These two, with the open boxes, these are low-income countries, the Gavi countries. And here's where you see the big difference in acceleration. There's a 7-year acceleration of pneumococcal vaccine uptake as compared to Hib. That calculated comes out to about 469 million more infants that are going to receive PCV in the first 20 years of its use compared to Hib. And more importantly, we're accelerating access to the most vulnerable. So go back to that bubble graph that I showed you before. This is a snapshot of Hib and Pneumo at the same place. And what should strike you is all the colored in bubbles on the bottom. Those are the countries with the high mortality risk due to pneumococcal vaccine, the big contribution to disease burden, and they are using these vaccines much earlier than they were at the corresponding same point for Hib, where a lot of those same circles are still open circles. And so you can then calculate, compared to your counterfactual of what would have happened if we had just rolled things out business as usual, what we would have, what kind of impact we're having on health. And this calculation puts the expected impact at about over 1.3 million deaths averted by 2025 as a function of having accelerated the uptake of pneumococcal vaccines compared to historical precedents. So are we any better at accelerating vaccine access than 10 years ago? Yes. But importantly, I think we've also learned some of what works and what doesn't to drive accelerated access. And I think that's really one of the key things about being in an academic institution, is we are the people who don't just want to see things work. We kind of want to know why, and we ask those questions. And I think as we try to retrospectively put it all together, what we see is there's this continuum that starts with evidence. It does start with the data, but you need to establish and organize that evidence in a coordinated, systematic way. And then you got to get it into the hands of policymakers. It's not enough to just publish it on the pages of the Lancet. You got to get it to the people who are going to use it to make policy decisions. And then once a policy decision is made, you have to continue to work to make sure that it's a priority to implement those policies, because there are tons of unimplemented policies all over the world. And making sure that it's a priority, that there's political will and systems to be able to carry out those policies, is a really important final step in creating access. And that's really what our center, the International Vaccine Access Center, is built around, these three strategic priorities: improving the evidence base for policy decisions, assuring that evidence reaches policymakers effectively, and building the commitment and systems to implement those policies. I want to wind up with what I think are three really important trends for us here in public health as we think about the next 10 years, 10 years that have been called the decade of vaccines by the Gates Foundation. One, most poor people live in middle-income countries, not low-income countries. This is a very big change from when we started with Gavi, when we started with this new vaccine introduction, and it will change the dynamic of our interaction with those countries and those poor people, and we must address it. And I encourage you to read this brief from the Center for Global Development that addresses this issue. Two, child mortality is declining, and rapidly in some places. And so the compelling humanitarian, juxtaposition of mortality rates here and mortality rates in other parts of the world is going to fade as a rationale for why we do things. We're going to have to change what we promise as the result of our efforts. We're going to have to focus on education and cognitive development and the health and well-being of families and households, not just the sheer moral injustice of high versus low mortality rates. And then lastly, we're increasingly coming to understand that health outcomes are determined by both non-health interventions and health interventions. And I think one of the things that we really could do better and need to do better in the decade ahead is find those cross-sectoral relationships, whether it's agricultural, education, or whatever, and try and work more closely, because they can have a big impact on our health outcomes as well. So my closing thoughts are vaccine access remains important and will continue to remain important. And we're doing better than in the past, but the situation is changing and we have to change with it. I hope you believe after this that academia can play an important role. I certainly do, and I know the team at IVAC does. And for those of you who are students in the audience, I hope you'll consider a career in vaccine access, because I think you won't regret it. So special thanks to the IVAC team, and thanks for listening.
That was great. So let me ask the first question. So what's the mechanism for the higher antigen or antibody response to a lower antigen dose?
I don't know the exact mechanism. I think the problem was that the company that licensed that vaccine did not do the immunogenicity extinction curves out to those low doses, so they didn't actually see that less was more, and they were third to market. So they found a formulation that worked, that they knew they could manufacture, that they thought they could make money on, and then they just plowed it through the development process. But I don't know the actual biologic mechanism that explains why less is more with that antigen, but it is uniformly observed in studies over and over again.
Right. So we should use these microphones, I guess, because this is being taped. So there's a microphone over there. If somebody could, Jim, maybe you could help me on that side. And let me ask, are there questions, other questions for Orin? Okay, Ken?
That was really terrific.
Thanks, Ken.
I wonder, a related question as to who or how is the dose decided by the companies that make it? Because obviously they'd make more money if they could, use a lower dose and get the same thing. And then the second sort of related question is, how about different routes? Like there's been a lot of studies on intradermal immunization where you can use a tiny amount.
Yeah.
Just put it in a different place, and some of these studies suggest that it works just as well. It isn't perhaps quite as easy to give an intradermal dose, but it's probably cheaper.
Yeah, that's a great point, and actually, I'm not surprised, Ken, that you brought that up, because the experience with hepatitis B vaccine has been that the intradermal vaccination, which is essentially teaching the vaccinators to go in at a really, flat angle to get it just under the skin and deliver it to presumably dendritic cells and whoever else is hanging out down there and does this great job of antigen processing, can actually give you a great antibody response with a fraction of the material. I'm not aware of studies with Hibben that have looked at the intradermal route. Most of them have been looking just at the fractionating the doses. But I do think, the other lesson for me really is how much antigen they put in the vial is not a driver of how much they charge us or how much it costs. So one company has already reformulated. Merck reformulated their vaccine. They started out with 15 micrograms of PRP. They went back, made a Hep B Hib combination that only had half as much Hib in it and worked, but they didn't pass on any of those savings to us, right? So the other thing about the formulations is even if you could do it that way, you'd have to count on the company to pass on their savings to you. So I don't think that's a really great way to go.
I think you were making the opposite point. So they could have, if they had recognized that, yeah, they could have made more money. So can I ask a question about the House of Cards analysis? You know, you had a point there that the greater proportion of healthcare expenditures that were private was associated with less of, sorry, excuse me, that's the drug companies calling here. Yeah. So so was that across all countries, or was that just in, say, the low and middle income countries?
We did the analysis both with all countries and then segmented to see whether there would be any, interactions or whatever. And I believe that finding was across all countries, but it's probably to a certain degree also correlated with the fact that in many of the poor countries with low immunization coverage, there's high out-of-pocket expenditures as well.
I get paid extra for this. When I do this, my contract's supposed to.
So Orin, you made a lot of wonderful points. It's too bad you had to learn them all over again. I've learned these over the 40 years. But I'm curious, what would you pinpoint as a thing that made WHO so relatively quickly, in my experience, make such a dramatic change in their recommendation?
I think there were 2 or 3 things that contributed to this. One is MATU and the Hib initiative, basically putting a lot more data right in front of them and saying, have you seen this data? Have you seen this data? Have you seen this data? Because years have passed since the last time you did one of these recommendations. Secondly, they had the benefit as well of, if you will, the frustration of the previous years, that they gave this recommendation, told people to, study the burden of disease everywhere. And then they had the realization it's not that easy. It's a really hard thing to do. And I think the third thing was just that kind of balance shifted, that it was, maybe we've really focused on misplaced precision here. Maybe after looking at the global disease burden estimates and all the data that are available and all those kinds of things, we'd be better off getting on with it and measuring the impact of the vaccine than holding up vaccine introduction to be able to answer all of these questions before we even get started.
So I think the bottom line message that you've shown, and it's so frustrating, is how idiosyncratic this decision making is and recommendations are. That you got to keep throwing it at their face and bothering them to get things done. And if you do great work and they don't do that, nothing happens.
Yeah, I mean, I think you bring up a really good point that it's keeping after it. And I often talk about the value of a dedicated team, that what really having a Hib initiative or Pneumo meant was there was a team of people who just sweat the details. They just worry about what's going on with the data and who's making decisions and how do we get them the best information available when they need that. But I think it's not idiosyncratic, Al. I think it's actually much more predictable than that. It's frustrating, but I don't think it's willy-nilly anymore. I think we've actually got a formula now. If you get the data, if you build the policies, and if you put the financing in place, that's going to solve a lot of your problems. But when you put only 1 or 2 legs of the stool up, it doesn't. We've had the money-only solution, it didn't work. We've had the data-only solution, it didn't work. We had the 2 of them together without the policy. But when we got that set together, I think that's where we really saw traction.
Okay, so Ruth, and then I think we'll break for the reception.
Orin, I was just wondering, you're talking about that 3-legged stool, and I was wondering about the Gavi recipient countries, and whether, in fact, also, when you think about what you learned from Hib and what you learned from Pneumo, whether those countries were learning in parallel, and whether there was a process of confidence building, such that when you brought all the data together, they were also more receptive.
Absolutely, and I should have probably emphasized it more in the presentation, but policy makers are not just WHO SAGE, right? It's also at the country level. And so together with the Hib initiative, we would put on regional forum where we would bring together all of the folks from, you know, a block of African countries, whether they're in the immunization program or the Pediatric Association or the communicable disease surveillance or whatever it was. And we would go through all this existing data, and very often they would say, I didn't know that. I didn't know there was so much data from my country, my neighboring country, the region, those clinical trials, et cetera. And seeing that now, I can see how this is an important vaccine for us locally. So it's really important to do both the global bit and the local bit simultaneously, and to, you know, build up their capacity locally to be able to absorb that data and make their own decisions.
Okay. Well, Orin, just want to repeat what Ken said. It was a great talk.
Thanks.
And thank you for doing it. And please come out and let's all have a chance to talk with a glass of wine or other beverage of our choice. Thanks.